modality. It's a wide topic, obviously, and it's very difficult to go over all types of focal hepatic lesions within a short presentation. But I'll try and give some ideas and maybe some pointers about the sort of things that might help in this process. So there are multiple modalities, obviously, used in the evaluation of focal hepatic lesions. Ultrasound and CT are mainstays in this evaluation, definitely. But I think when it comes to the aspect of focal hepatic lesions, really MR is probably the best modality in both the detection and in the characterization of these lesions. Nuclear medicine also still plays a role in some situations. Some of the more interventional procedures have probably fallen off to a large degree and very rarely, I think, are used these days. Obviously, MR, you know all the advantages of MR, non-ionizing radiation, the improved tissue contrast compared to the other modalities. There's improved, as I mentioned, detection and characterization of focal lesions in comparison to the other modalities, and its ability to utilize, or the new contrast agents that are available, particularly tissue-specific contrast agents, have become available that also allow for characterization and detection of these lesions with a high degree of accuracy. There are some disadvantages, obviously, as with any imaging modality. Obviously, there are contraindications for some patients with certain devices that may not be able to enter the MR environment. The examination length and cost is more than with some other modalities, and therefore may be a prohibitive factor in doing this, except in certain situations. And it needs some expertise, obviously. Patient cooperation is important. Some patients are claustrophobic. They're unable to hold their breath. They're unable to lie flat for a long period of time. So this also can be an issue. There are some artifacts that you need to be able to manage with the liver imaging, and either to avoid or to overcome these artifacts. And we know that MR is not good for detection of calcification. And there is the issue of nephrogenic systemic fibrosis with the gadolinium agents now, particularly in patients with renal function impairment, that you have to be careful with. Just to mention some of the artifacts that we face, obviously you can have many artifacts that you need to deal with occasionally, and this is where some of the experience and expertise needs to come in to handle these. The respiratory motion artifact, that particularly in patients who have irregular breathing rates. There's also patients sometimes with ascites on the T2 weighted images can generate a lot of artifacts that make detection of lesions a bit difficult. There's also, particularly with the higher field units, the 3 Tesla units, many times you may encounter these dielectric effects, although I think most of the vendors are starting to overcome this now with the newer units. And in addition to that, you get the pulsation artifacts that occasionally can simulate lesions. So all of this you need to be careful with when you're dealing with MR of the liver. For requirements, you need high-performance gradient systems that are capable of fast imaging, particularly in a breath hold. A lot of the imaging is done with breath holding, particularly in the dynamic phase of the exam. This will help to reduce the artifacts. If the exam is done faster, patient tolerance is improved. You can perform dynamic imaging, as I mentioned. The use of phased array torso coils will improve your signal to noise, and the parallel imaging techniques are very important again in improving either your resolution or your time of acquisition. The automatic contrast injector is very important, and also utilizing the workstation for post-processing is very important as well. What we tend to use mostly is dual echo T1 weighted gradient echo and a breath hold in phase and out of phase imaging. We obtain T2-weighted images with fat suppression. This can be obtained in multiple different ways, either with respiratory triggering or navigation, or can be done in a breath hold, and sometimes you need to tailor this according to your patient. Some people with older systems, particularly lower field systems, might use stir imaging where fat suppression is not effective. Diffusion-weighted imaging, I'll talk about this more later on, is also becoming more and more important in the evaluation of the focal hepatic lesions. And then the dynamic contrast enhanced sequences as well, which is extremely important. So the in-phase and out-of-phase imaging, as I mentioned. The T2, you need to use fat suppression. This improves your contrast to noise. It can be done with respiratory triggering or navigation, or with breath holding, as I said, or the single shot or half Fourier reconstruction. Particularly, this is useful in patients who have difficulty with breath holding, and may help in that situation. So, for example, a patient like this who had a T2 weighted image with fat saturation and respiratory triggering, you see all the artifacts that generated by the respiratory motion. But when we do the breath holding sequence, then you can see that there's much improvement and reduction of the artifacts. And even with the single shot sequence, although it's a bit more blurry maybe than the breath hold sequence, but still you can get probably better detail in these patients who have problems with breathing artifacts. Just to mention that respiratory triggered fat spin echo imaging has been shown to detect more lesions than the old conventional spin echo sequences or with stir. So it's a very helpful technique in the evaluation of the lesions. In fact, even now with diffusion-weighted imaging, it's probably felt that this may even, and particularly in the higher field units, may even be better than T2. Diffusion-weighted imaging is this single-shot EPI technique with fat suppression. It's obtained usually in the three orthogonal directions. It can be done either with a breath hold or with free breathing, and we usually get several B values, at least to obtain at 0, maybe a low B value and a higher B value. You can obtain more B values if you're interested in getting more accurate ADC curves. The dynamic 3D sequences are better than the 2D sequences, and obtaining the signal to noise is much better, and you can obtain thinner slices which will help in reformatting and reconstruction better quality images. Are similar or better to contrast to noise as compared to the 2D sequence, and the coverage of the entire liver in a breath hold is possible, and fat suppression is very important. So you end up getting, usually you'll end up with a late arterial, a portovenous, and equilibrium phase as you would obtain with the CT scan. But you can add any additional sequences that might be required as well, particularly the particular benefit over CT because there's no radiation penalty here. Sometimes you might add some additional sequence in certain situations. Through FISP imaging may be helpful in situations where you're looking at, particularly at the vascular structures, and may be unable to administer contrast. This could be one alternative. The use of some of the tissue-specific contrast agents required doing some other techniques occasionally, like with the reticular endothelial-specific agents. We acquire T2, gradient T2 star-weighted imaging. And you can also utilize hepatobiliary agents, again using basically the same 3D T1 weighted sequence. So that was just a quick overview of how we do the MR. To proceed from there is to think of the items or the things that you require in order to characterize a focal hepatic lesion. And it really starts from before the imaging, actually. So, we need to have a good you need to have a good understanding of the history of the patient. But then also specific tissue characteristics will be looked at, T2 signal, the enhancement pattern, and then the use of some of the newer MR contrast agents and the use of diffusion-weighted imaging as well. So the clinical history, sometimes that can provide you with very important information. Just knowing the age and sex of the patient often can narrow down your differential diagnosis of focal hepatic lesions. Knowing whether or not they're on any type of medication, particularly contraceptives or steroids. The presence, understanding or knowing that the underlying liver disease is present or not, if they have hepatitis or cirrhosis or other underlying hepatic disease, and whether or not there's any extra hepatic malignancy that harbored with the patient. So all of this, plus other information, is central, I think, to being able to focus your differential diagnosis. So we should not underestimate getting good clinical history. The enhancement pattern is somewhat similar to contrast-enhanced CT, basically. It's the same concept. So we look at pattern of vascularity, we look at homogeneity and intensity of the enhancement pattern, and also the washout or the enhancement pattern on delayed imaging. If you look at the enhancement pattern, you can basically categorize them to some extent into hypervascular lesions. These could be either benign or malignant, so you'd have lesions such as focal nodular hyperplasia or adenomas, which show arterial enhancement, all the same with the hepatocellular carcinomas. Other lesions will tend to be more hypovascular, and again, these can range between benign and malignant lesions. Some, particularly in the cirrhotic environment, some regenerative nodules will be hypovascular, and metastatic lesions from many primaries will be the same, just as examples of that. Or they may be completely avascular in a situation for cystic, particularly in cystic lesions. Simple cysts or hydatid cysts or biliary cyst adenomas all can give you an avascular pattern of enhancement in the dynamic scan. If you look at the delayed scan, looking at the equilibrium or delayed phase scanning, then you want to see what the characteristics of the enhancement are at those phases. With hemangiomas, you tend to get retention of contrast. The pattern of retention obviously is well known to you, but you can also see that in other lesions such as cholangiocarcinoma, where there's a high fibrotic component, so that the presence of delayed enhancement can be a helping factor in determining the type of lesion you're dealing with. Alternatively, you might get washout from the lesion on the delayed phase. So that here's the arterial phase and then the delayed phase. So you can see the lesion is washing out, and this is commonly seen feature of hepatocellular carcinomas and metastatic lesions as well. And some of the benign lesions, however, the degree of washout is not so prominent. So these the benign lesions tend to not to wash out as they do with the malignant lesions. So for example, with this adenoma, where you can see that the soft tissue portions of the lesion still retain the contrast to an iso-intense level with the background liver. And this is true also for lesions like FNH and many benign lesions. The other aspect to look at is the specific tissue content of the lesion. And MR is very good actually in doing this, because you're able to detect the presence of fat. You can characterize the presence of hemorrhage, looking at if there's a central scar or fibrosis or iron. All of this can be fairly accurately characterized by MR imaging. But as I mentioned before, calcification is a weakness. So particularly with the dual phase T1 weighted imaging, it's very easy to diagnose the presence of focal fat in the liver. You can see the signal drop on the opposed phase imaging, which allows very accurate diagnosis of the presence of focal fat infiltration. It can also help in the opposite direction, where you have diffuse fatty infiltration and might see some focal hepatic lesions that may simulate either benign or malignant lesions, but can be quite nicely characterized as well by MR as just focal fatty sparing. The presence of hemorrhage, again, is quite accurate in the detection or in the characterization of presence of hemorrhage. With the T1 weighted fat suppressed sequences before contrast, the high signal intensity of hemorrhage can be nicely depicted and can narrow down your differential diagnosis to the lesions that commonly have hemorrhage, such as adenomas, and some malignancies as well. A central scar is a characteristic feature of FNH, obviously, but these can be seen in some in hepatomas and in fibrolamellar cancer, for instance. But again, it can be very nicely demonstrated with in the early phase where there's little enhancement, but then the retention of the contrast in the delayed phase within the central scar tissue. The iron deposition is also very nicely characterized. The presence of siderotic nodules within the liver, demonstrating the susceptibility artifacts on all sequences, basically, and is very helpful, particularly in the cirrhotic case, because it is usually or almost always an indicator of either a regenerative or dysplastic lesion, and hepatomas tend not to have much siderosis. The other aspect is to evaluate the T2 signal of the lesion, and this I consider as a major advantage over the contrast-enhanced CT examinations, which look basically at enhancement. I think the ability to look at T2 signal, I think Professor Lagi also mentioned this earlier, that this is an additional factor in some cases where you may have problems in characterizing lesions. So looking at T2 signal can be quite helpful. And if you look at them, the degree of intensity, you can subcategorize them to some extent. Lesions that are markedly hyperintense tend to have fluid content mostly. Cysts, hemangiomas, necrotic metastases may show very high signal intensity. Some solid metastases may do this. Mucinous metastasis, for instance, can demonstrate very bright signal on T2. Iso-intense or moderately hyperintense lesion usually indicate a solid lesion. Many times oftentimes it's more worrisome for a malignant solid lesion, but some benign lesions may do this. And then on if you get low signal intensity on T2, then you'll be considering the presence of fibrosis, maybe siderosis. Since the imaging is done with fat suppression, and maybe the presence of fat may show low signal intensity as well. And then the other aspect to look at is the heterogeneity of the lesion, or the T2 signal. Just a few examples of this. So with the markedly hyperintense signal, as I mentioned, is usually an indicator of the presence of fluid content. So you may see this in simple cysts, hydatid cysts. Abscesses will show marked hyperintensity. Hemangiomas, all of these fluid-containing lesions will demonstrate quite bright signal on the T2. Alternatively, with the hypointense signal, this is, for example, in cirrhotic cases, is very helpful in characterizing the type of nodule you're dealing with, as low signal intensity is often seen with the regenerating or early dysplastic nodules. Tend to have low signal intensity. If you start developing a malignancy, then the T2 signal will often transform into high signal intensity. Again, as I said, with siderosis, you can see that on all sequences they tend to remain low signal intensity on the T2 weighted images as well. Even lipomas as well, although they're on T2 weighted, you would expect them to be bright, but since we do this with fat suppression, these will tend to be low signal as well on the T2 weighted images. And then the iso to moderately hyperintense lesions. The ones that are the more moderately hyperintense they are, the more chance they are likely to be malignant. You see this with hepatoma, for instance, with cholangiocarcinomas. Sometimes some of the benign lesions may be very mildly hyperintense, although they, particularly adenomas, but FNH sometimes may be very mildly hyperintense as well. Just to mention a few words about nodules and hepatic cirrhosis. Again, as I mentioned earlier, MR is a very helpful technique in distinguishing the types of nodules that you are dealing with. It's a much more complex setting of trying to distinguish what type of nodule you are dealing with. And MR, I think, clearly has an advantage over other modalities in characterizing these lesions. Regenerating nodules tend to be variable on T1, but they're almost always low signal intensity on T2, and they will not show arterial enhancement. Alternatively, when you develop hepatomas or hepatocellular carcinoma, again the T1 signal may be variable, but then the signal on T2 tends to increase. It may become quite heterogeneous as well. You tend to start seeing arterial hypervascularity. And with the delayed images, on the delayed or equilibrium images, you may see a capsule, a well-defined capsule around the lesion with mosaic pattern of washout on the delayed images. Occasionally, you'll run into this nodule and nodule appearance, as I showed you an example of that earlier. The presence of fat sometimes may also be noted within hepatomas, and then also the associated finding of portal vein or hepatic vein thrombosis can be a strong indicator of the transformation to hepatoma. Some examples of that is for this lesion in a patient with cirrhosis, where it's bright signal or moderately hyperintense on the T2 weighted sequence. On the T1 weighted, it's very mildly hypointense, and you can see the intense arterial enhancement on the post or on the dynamic scan. But in addition to that, you'll notice that there's also actually another lesion here. So there's a lesion that is slightly hyperintense on the pre-contrast T1, but has a central hypointense lesion within it that enhances on the arterial phase and shows some bright signal intensity on the T2 weighted image. So illustrating this so-called nodule and nodule appearance of the early hepatoma developing within the background of a dysplastic nodule. So the characterization can be quite vivid and quite accurate with the proper use of MR. The other aspect, as I mentioned, is in the delayed phase, you'll see the rim of or capsule of enhancement. You may see the mosaic pattern of washout in the central portion of the lesion, and then the additional feature of portal vein thrombosis can also be a very helpful feature in indicating the presence of tumor. For example, in this patient who actually had a very infiltrative mass throughout the left hepatic lobe, in addition to the focal lesion here. To mention, the next item to mention is the use of some of the newer hepatic MR contrast agents. There's a whole variety of agents that are that have come out in the recent past for use in the characterization and detection of focal hepatic lesions. They're broadly characterized into the extracellular gadolinium-based agents, which we all have been using for a long time. But there's also the liver-specific agents, or so-called hepatobiliary agents, and then there's the reticuloendothelial system-specific agents, which are iron oxide agents accumulated within the reticuloendothelial system. And there are some also blood pool-specific agents. I'll just mention very briefly a bit about some of the liver-specific and reticuloendothelial system agents. With the hepatobiliary agents, as an example of that, is the gadolinium OB, DTPA, or otherwise known as Primovist, as allows for dual evaluation. So you're able to obtain your usual dynamic imaging as you do with the gadolinium-based, extracellular gadolinium-based agents, but you have the added ability of doing hepatocellular phase or hepatobiliary phase imaging usually obtained at around 20 minutes, that allows for imaging after accumulation of the contrast agent within the hepatocytes, because they are accumulated and excreted into the biliary system and can be imaged in this way. distinguish its capabilities in distinguishing between lesions with functioning hepatocytes, such as focal nodular hyperplasia or some well-differentiated hepatomas, and those that are devoid of functioning hepatocytes. So lesions like metastasis, cholangiocarcinoma, some of the poorly differentiated hepatocellular carcinomas will not accumulate this agent, and this can help significantly in characterizing these lesions. Compared to CT or pre-contrast MRI, this has been shown to enhance the detection of lesions, particularly with the smaller lesions can be quite nicely depicted by using the use of this agent, and it improves the accuracy of lesion characterization based on what I mentioned earlier. Further studies still needed to determine, though, if there's any improvement over just extracellular agents. Here's an example of a patient who had a breast cancer and had on the T2 image. It may be very difficult to say that you see any lesion at all, but I think on the hepatobiliary phase it's quite clear that you can see that there is a lesion that is, I think, much better demonstrated on the hepatobiliary phase. You can see there's also another larger lesion, which actually was demonstrated on the T2. But I think even when you go back in retrospect, you might be able to pick the lesion up on the T2 weighted image. But I think you would agree that the confidence of your ability to pick up this lesion is enhanced with the hepatobiliary agent. Also, in terms of characterization, it can be very helpful. Here's a case of a hepatic adenoma, which was on the pre-contrast imaging. You can see that has some fat content, has bright signal on T2, and demonstrated after the administration of the contrast agent, in the dynamic phase, you can still demonstrate the hypervascularization or the arterial hyperenhancement in this lesion, but then you can see on the hepatobiliary phase that there is some decrease in signal intensity within this lesion, which is characteristic of the adenomas. Because of the absence of biliary tracts within the lesion, this can actually be helpful in distinguishing this from focal nodular hyperplasia, which tends to retain the contrast on the delayed scan. Reticuloendothelial agents, specific agents, are trapped. This is the second category of agents that can be used in MR imaging. These are trapped by lesions containing Kupffer cells, such as FNH. They're dispersed within vascular lakes, such as hemangiomas. Metastasis and cholangiocarcinoma do not pick up these agents because they do not have reticuloendothelial system cells. And hepatomas and adenomas may be somewhat variable depending on the degree of differentiation and the degree of Kupffer cell, residual Kupffer cells. But a substantial or more than 40% signal loss is considered to indicate that this lesion is a benign lesion. You look for the inverse contrast effect, so this causes a decrease in signal intensity. We use the T2 weighted or T2 star weighted imaging to evaluate these, and because it causes susceptibility and decreases signal intensity. And you have a window of 10 minutes up to several hours actually to perform the imaging, which can be very, so you have a lot of time to be able to do this type of imaging. This is just some examples of that. Here's a case with the T2 before and after the injection of the reticuloendothelial agent. You can see that there is a continued drop in signal in the background liver, but also within the lesion itself in this case. Whereas in the other case, where there's a bright signal, there is no drop in signal after the administration of the agent. So there's a focal nodular hyperplasia which accumulates the agent and loses signal, as opposed to a metastasis that does not accumulate it. It can also be helpful in detection. I think this is a patient who had a primary malignancy, was evaluated for metastasis. I think it would be very difficult to say for sure if you have any metastasis in this case. There may be some heterogeneity, but following the administration of the contrast agent, it becomes very clear that there's actually very widespread metastasis throughout this liver. If I have time, maybe just two or three more minutes, I'll finish with the diffusion-weighted imaging. This is an integral part for a long time, has been an integral part of CNS imaging, but is now more and more becoming utilized in the abdominal imaging, and particularly in hepatic imaging. It's based on the physiological Brownian motion of water molecules within tissues, and essentially based on the presence of molecular diffusion of water, but also the microperfusion has a role to play, particularly at the lower B values of when we're doing the diffusion-weighted imaging. You can obtain it either in a breath hold or with free breathing. Free breathing could do it either with respiratory triggering or without. And the assessment can be either qualitative or quantitative. With the qualitative assessment, basically you look for patterns of signal intensity at the 0 B value, at the high B value, which could be 500 or higher, and then the pattern on the ADC map. So it's very important to look at the ADC image as well. Benign lesions tend to have bright signal on the lower B value, but they may or may not lose signal on the higher B value, depending on the presence of a T2 shine through. If there's T2 shine through, then the signal will remain high on the ADC. So the ADC map in these situations will continue to show you high signal intensity. The malignant lesions will remain bright on the high B value sequence, and will show you will show a decrease on the ADC map. So just some examples of that for a patient with a benign cyst here. This is on the B0, the B500. You can see it still remains bright on the higher B value, but when you look at the ADC map, it's also bright. So this is telling you that this is a T2 shine-through effect of this lesion because of the high fluid content, as opposed to this lesion where there's again high signal intensity on the higher B value, but looking at the ADC map, you can see that there's a loss of signal. So this is a restriction of diffusion within this lesion, and very very consistent with a malignant lesion. You can also do this quantitatively by putting regions of interest on the ADC map at on the lesion, and many people have worked on looking at ADC values and their utility in differentiating benign from malignant lesions. Here, generally speaking, the malignant lesions tend to have a relatively lower ADC value, whereas hemangiomas or benign lesions will tend to have higher values on the ADC map. This is again illustrated by, for instance, one group looked at the distribution of ADC values between benign and malignant lesions. You can see that there is a separation in distribution, where above a value of 2, essentially, you would see none of the malignant lesions. Below a value of 1, none of the benign lesions. There is some overlap, but this can be a helpful tool in the differentiation. And they were using a threshold of about 1.5. You can demonstrate quite good sensitivity and specificity for the detection of malignant lesions. This has been expanded further. Multiple other groups have looked at the ADC values and the differentiation. We noticed that most of the malignant lesions tend to fall in the lower range. Most of the benign lesions will fall in the higher range. And there are some lesions that fall there's an overlap, particularly with lesions like FNH and adenomas. So using various cutoff values, you can see the various sensitivities and specificities that were obtained can be quite specific and sensitive. There's still some issues about standardization of these values. B values still haven't been completely standardized, so you do get some variability, but it shows the promise and the capability of this in doing this evaluation. So the diffusion-weighted imaging has been shown in multiple studies to be better than T2-weighted imaging in lesion detection and in characterization. And in many centers, actually, it's even replacing T2. It can complement information from contrast-enhanced techniques and could serve actually as an alternative when you're unable to administer gadolinium-enhanced agents such as in severe renal insufficiency, and has shown actually a lot of promise even in the assessment of tumor treatment response as well. So in summary, fat-saturated T2-weighted imaging and dynamic gadolinium-enhanced sequences are probably the cornerstones of hepatic MR imaging and the characterization of focal lesions. Pattern recognition can allow accurate characterization of most of the hepatic lesions by MR. And the use of new MR contrast agents is improving both detectability and characterization. Diffusion weighting images is now playing a progressively greater role in the evaluation of focal hepatic lesions. Thank you.
I would like to thank you, Dr. Kari, for this outstanding presentation.